Good evening, everyone, and welcome to the February 2025 Scotland Virtual ITP Patient Meeting. It's my pleasure to welcome Dr. Catherine Bagot here today. Catherine, as you know, is one of our medical advisors and comes from Glasgow Royal Infirmary. In addition, we've got a number of our ITP people here as well today. Anthony Hurd, Rhonda Anderson, Diane White. Plus, we've also got Davey, one of our ITP colleagues from the ITP Association in Denmark, and also Patricia Conroy, who's actually in America at the moment, but Patricia is the organizer of our East Sussex patient group down there on the coast. The first question we've got today is regarding Avatrombopag.
Your platelets were more than 30, if your platelets are more than 30, because we know the risk of bleeding is very low once your platelets are greater than 30, and in fact once they're greater than 50 you're really at no bleeding risk at all. But if someone had a platelet count of 20 and had no bleeding symptoms, then you still might not start it. But generally I suppose, to keep it simple, the cutoff would be your platelet count would need to be less than 30 to consider using it, but that would depend on your bleeding symptoms as well.
Okay, even if there's no bleeding?
Well, if there's no bleeding and the platelet count is, say, 25, depending on all the circumstances, you don't have to have treatment. We try and move away from what actually the platelet count is and more what the bleeding symptoms are, and also what other bleeding risks the patient might have. So, for example, if someone had a platelet count of 25 and they were having problems with blood blisters in their mouth, having slight nosebleeds, then we definitely would start treatment, and Avatrombopag is certainly a treatment that could be considered. Although Avatrombopag does varies from person to person, but can take a week to 2 weeks before you start seeing an effect. So it depends how bad the bleeding symptoms are. But if someone's having mild bleeding symptoms, the platelet count was 25, then I would consider it appropriate to start some form of treatment, and Avatrombopag could certainly be that. If the bleeding symptoms were a lot worse, then you might need to add in something else when you first start Avatrombopag to make sure that you got a response in the next sort of 2 or 3 days. That might be some prednisolone. If the bleeding was very bad, you might use immunoglobulins, which is the infusion that's given into your arm if you've got real bleeding problems.
Okay, what are the side effects? Are there any side effects
of Avatrombopag?
Yeah.
It's quite well tolerated, actually. So as you may know, it's one of these drugs similar to L-Trombopag and Romiplostim, which doesn't suppress your immune system like so many of our older drugs did. So ITP is all about making platelets with no problems at all, but destroying them too quickly. So what we've always done up until about 10 years ago was give drugs that suppress the immune system to stop the platelets being destroyed so quickly. But now we have these other drugs such as Avatrombopag, which stimulate the bone marrow to make more platelets. So one thing about Avatrombopag, it's not suppressing your immune system, so that's a good thing. We also know that unlike some of the other drugs such as L-Trombopag, it doesn't cause your liver to get inflamed. So that's another good thing about Avatrombopag. One thing that a few of my patients have mentioned to me, although it's not too bad a side effect, is that they notice their hair goes a bit thin. And ladies in particular may notice that. For example, I've got a 60-year-old gentleman on Avatrombopag at the moment, and he feels that his hair's got a bit thinner, but he doesn't really mind because he felt he was going thin anyway. So but that's something to be aware of. And the other thing I find with Avatrombopag is a lot of platelet fluctuation. So all of these types of drugs can cause fluctuations, but Avatrombopag I found particularly fluctuating. But overall, in terms of side effects for the patient, very, very minimal. Really, really, really well tolerated. Anyone who goes on Avatrombopag, we explain to them that there is possibly an increased risk of blood clots. So we know that even though people with ITP have a low platelet count, which puts them at increased risk of bleeding, actually they're also at increased risk of blood clots. And we think that's because the platelets that are being made are very, very new. But yeah, they're at increased risk of mainly blood clots that affect the veins, but possibly even blood clots that affect the arteries, such as with heart attacks and strokes, although the evidence for that isn't quite as good.
Okay. Thank you.
Okay. One of our patients here, Diane, is on Avatrombopag.
Sorry, I was just going to add to that a bit because I'm a bit of a lifer when it comes to ITP. So obviously I've been on all 3 TPOs, and with Avatrombopag, I did lose hair quite dramatically. It was scary, you know, it's coming out in handfuls, blah, blah. Romy, I was getting a lot of side effects. So for the second time, I'm on Ava, and I have to be honest, of all of them, I'm finding that the best tolerated. I haven't had any hair loss. I'd agree with you that it takes a while to kick in, and probably more than a few days, actually. I mean, I'm about 5 weeks in now, and I think I'm only just starting to see improvement in sort of daily quality of life, if I'm honest.
Yeah.
And the one thing that did happen for me is that I got kind of asthma-like symptoms about 3 or 4 weeks in. But we've sorted that now. So fingers crossed. I think across the board, and I say this having talked to other clinicians around the country, it does seem to be the one that's got the less side effects and the most benefits, really.
So I think one thing I think I'd say about ITP is it's so variable, and so I mean the studies say that it's an average about 3 weeks before any of these drugs like Avatrombopag and Antiplatelet start to work. And then I've had patients who've seen a change in their platelet count within a few days, and others that have taken 6 weeks to have an effect. So because often, you know, if you need a higher dose, it can take longer. And I would definitely agree with you that I think my patients who've had hair loss, it's been far worse on Avatrombopag than it has been on Avatrombopag. But it has now happened to me, well, with a patient on Avatrombopag as well. And it's interesting as well. So, you know, patients will often mention quite a lot of side effects. And if you ever look, I don't know if any of you have looked at the sort of summary of medicine characteristics that you can actually see online. They're available to everyone. Most drugs cause most side effects, which can make it really, really tricky. But yeah, hair loss is something that I've seen in quite a few patients now with Avatrombopag.
Okay, thank you. Right. Any other questions before I go to the list I've got? I've got one from Liz. Are these your questions, Liz? You're on the call. She's trying to, yeah. Right, I'll ask the first one. Is it true that research has shown that ITP patients are at a higher risk of cardiovascular disease? If so, should there be a case for ITP patients also to be assessed by cardiologists? Yeah. And I know I gave Catherine.
You did. I've been doing my homework. So there isn't really good data out there. So we've always sort of thought, oh, you know, are ITP patients a bit more at risk of clots generally, and whereas we really know that with venous thrombosis, so blood clots in the legs and the lungs, it's never been quite such a thing with heart attacks and strokes. So I had a look through the evidence. So the evidence is quite weak. There aren't great studies that, you know, can say yes, you're at increased risk of heart attacks and strokes. But there has been some work done, sort of looking at you know, various populations, and there is possibly a slight increased risk of heart attacks, strokes, really anything where you've got blood clots in the arteries. That's heart attacks, strokes. You can also get blood clots in the lower limbs, in the legs, which is also known as peripheral vascular disease. But I wouldn't. It's quite weak. So basically, I actually wrote it down here. So in this really big sort of database collection they followed up patients for 6 years, those with ITP and those without. And the data set was really big. Like of ITP, there are like 1,000 patients, and I can't remember, like 20,000 patients who didn't have ITP. And the absolute risk over 6 years was 6% in the ITP group and 4.7% in the non-ITP group. So yes, there's a difference, but it's not huge. It's not like double the risk or anything like that. And I think the thing with this, obviously, those people are actually quite young, which was interesting. So they were like in their late 40s, early 50s, like their average age. that's quite young really to be looking for heart disease. But I think the main thing that's important is, you know, and the things they didn't know, what was their ITP like at the time? What drugs were they on? What other confounders were there, like family history of heart attacks was so important. What was their cholesterol? What was their blood pressure? What was their, you know, what sort of level of diabetes did they have? There's a lot we don't know. But I think my humble opinion would be ITP patients definitely don't need to see a cardiologist just because they've got ITP. But I think what I would say is it probably just stresses how important it is, true for everybody, but also true for patients with ITP. Keep fit, keep healthy, normal weight, don't smoke. And maybe it all dropped a bit because of the pandemic, but it used to be, particularly in Scotland, that you were invited up to your GP, maybe when you were 50 and then you were 60 and when you were 70, to get your blood sugar checked, to get your cholesterol checked. I think that's fallen a little bit by the wayside. So maybe something to be said, maybe if you have ITP, is to say, perhaps, you know, do make sure you go to your GP at some point, get your blood pressure checked and your cholesterol checked and your blood sugar checked, just to make sure you don't have any of those other risk factors. But otherwise, it's all a bit boring. Fit, healthy, normal weight, don't smoke.
Great stuff. Great stuff.
Thank you.
Does that answer that question, Liz? Yeah.
Yes, thank you. Yes, I was wondering if there was
there is another one here, and
yes,
one
I've
of the
written a
words I'm
few.
gonna
Well,
try and pronounce.
Well, I've done all my homework for Liz.
Oh,
Excellent.
thank you.
Right. The next one, dual antiplatelet therapy, i.e. aspirin and clopidogrel.
Clopidogrel. I don't know who names these drugs. It's like
I've no idea,
Avatrombopag.
but that's a real tongue twister for an old bloke like me. Are these recommended after cardiac bypass surgery?
So in terms of, so what's so interesting about this, if you forget ITP for a second, the cardiology world are uncertain about exactly the best thing to do after. Now this was the cardiac surgery one, wasn't it, Mervyn?
It was, yeah.
So even cardiac surgeons are not absolutely certain exactly what should be done in terms of platelet management after managing platelets afterwards. So if you move away from ITP for a second, they definitely know you need aspirin, but whether you need additional to aspirin is unknown in the non-ITP world. And there's quite a lot of studies out there saying that maybe you should have an additional one, but if you have an additional antiplatelet agent, does that you may get maybe some benefit that the grafts have been put in, you know, someone's had a heart attack, they've got blocked arteries around their heart, they have bypass surgery, and there is some evidence that in your aspirin plus one other drug that works against platelets, that maybe you do improve the flow rate through these grafts, but at the expense of more bleeding. So we don't actually, it's not known by cardiologists what you should do.
Right.
When it comes to ITP, then that's even more complicated, because you've got that additional bleeding risk is if someone's sitting, you know, needing bypass surgery and they're sitting with a platelet count of 35, you know, what should you do? And that really comes on to what we all think the threshold is, say in ITP, for someone who may need aspirin, may need clopidogrel, you know, what's a safe platelet count? And we don't really know that either.
Okay.
So if your platelet count is greater than 50, you can pretty much do anything. You can be on aspirin, you can be on clopidogrel, you can receive warfarin. You're not at risk of bleeding, and therefore you can receive all those drugs. But once it's less than 50, the jury's a bit out. Probably, as we know, we've got this threshold of 30, where if it's greater than 30, your risk of bleeding seems to be very, very small. So we're pretty comfortable that if your platelet count is greater than 30, you can definitely be on aspirin.
Okay.
Could you have aspirin and clopidogrel if they're, say, 35? Often what I'd say, let's say someone's got really, really bad heart disease and the cardiac surgeon or the cardiologist says, because one of the things we don't do quite as much bypass surgery as we used to, because we now have these stents that you can put in. It's far less invasive. But we do know as well that these stents can block off, and it's quite common, say, to have both aspirin and clopidogrel for 1 to 3 months after the stent's been put in to make sure it doesn't block off.
Right.
It might be you just had a stent put in, you've got a platelet count of 35, and it's like, can we use 2 antiplatelet agents? And my answer to that would be, well, if it's really, really neat, it's a balance of risk of losing that graft, that stent, versus the risk of bleeding. So you've got to look at, you know, that person who's got ITP, what's their bleeding symptoms been like in the past? Are they someone that has a lot of bleeding or doesn't have a lot of bleeding? And it'd be a balance of risks and benefits. But if I had an ITP patient with a platelet count 35, needed aspirin and clopidogrel, and they didn't have much of bleeding history, I'd say, well, I think on balance, probably having both for as short a time as possible is the best thing to do. And then if someone started getting blood blisters, you'd have to sort of say, well, actually, we need to withdraw one of them. So it's really an individual, although the platelet count comes into a little bit, it's really a very much case-by-case decision.
Okay.
Okay.
Thank you, Catherine.
Thank you. Yeah.
There's just a couple more on the cardiac front.
Yeah.
Is a lifelong dose of aspirin safe for the over 65-year-old ITP patients?
Now that's an easy one, because so if you have never had a heart attack or a stroke, there's no evidence of benefit taking aspirin at all. So what we might call primary prevention, so trying to prevent the first stroke or the first heart attack, they demonstrated a few years ago now, no one needs it. All you're going to do is cause more bleeding. So if you're just talking about, you know, the general population over the age of 65 with ITP, they do not need aspirin, which is good.
It's good. But if somebody has had a history of a heart attack, and they've got ITP, they should go on aspirin.
So this is interesting, and this is something I've been learning a bit about over the last few years. So it used to be, yes, if you'd had your first heart attack, you were on aspirin for life. But actually, the cardiologists now have this expression of stable ischemic heart disease. So ischemic heart disease covers all bases like angina and heart attacks. And so if you, as far as I understand, if you've got you may have had a heart attack in the past, you haven't got a stent, you haven't had bypass surgery, but you did have a heart attack in the past, but you've had no problems for at least a year, you don't have to be on aspirin.
Okay.
Good one.
Sounds good.
Finally, just another one. Are there any research projects looking at the safety and efficacy of no antiplatelet therapy 3 months after bypass surgery for ITP patients?
So there's no surgery. There's no research for the non-ITP patients. Never mind the ITP patients. So I mean, there's lots of observational stuff out there, you know, but an actual trial to say this is better than that, no. And it probably needs doing. And the thing about cardiology trials is that, unfortunately, there's so much heart disease in this country. You can actually recruit quite well to these trials. But yeah, it's something that would need to be done by the cardiologist. And this would almost certainly not include ITP patients, I'm afraid, because you have to be fit and well, except in the affected organ, to go into a clinical trial.
Yeah.
Thank you
for answering.
Happy with that? Yeah.
Yeah. I would summarize that probably if you've not had a bleeding history and you've not bled very much, or had bleeding symptoms, but you have to go on the aspirin, and you've got counts around about 50 or above 30, it should be safe enough then to take.
Above 30 for aspirin is almost certainly safe enough, yeah.
And somebody that's not had a kind of bleeding history, or even a clotting history, I mean, thrombosis or anything.
Once you get a thrombosis in ITP, it's very, very tricky, because then you start getting worried about using things like Avatrombopag and Avatrombopag and Romipostol as well. But generally, what I think I would say in a summary is that if your platelet count is over 30 and you've got quite a bad problem with heart attacks, strokes, a stent in one of your coronary arteries, bypass, you've got quite a lot of options. If your platelet count's above 30, caution.
With caution, you can take the aspirin.
Definitely take the aspirin, and possibly, if you haven't got much of a bleeding history, you could go to this dual antiplatelet therapy with clopidogrel.
Okay. Thank you. Yeah, that's answered all my questions.
Lovely.
Thank you very much.
Thank you very much, Liz. Thank you. Right. Anyone else got any other questions? Right. A few things coming up. Anthony, do you just want to speak about Rare Disease Day that's coming up?
Oh, yeah. Thanks, Mervyn. Yes, people may already have information on this, but every year we have Rare Disease Day on the last day of February annually. It's been going now since about 2008. We at the ITP Support Association have been involved in it since 2010, and we take an active sort of participation in the various events, and obviously get behind it and promote it quite vigorously. There are some great benefits in that, in the sense that from our participation in it, we've got a huge amount of positive feedback from the rare disease community out there, and people may know that ITP is just one of over 6,000 recognised rare diseases. It's one of over 80 autoimmune conditions. So, it's good in some senses to know that we're not alone in our sort of day-to-day battles with our condition. In terms of finding out more about it, I mean, I'll perhaps encourage, I'll put the websites up in a minute on the chat. But, it's very easy to get involved. If you keep an eye on our social media sites, you'll see that I'll be posting out information on rare diseases every day for the month of February. So please do get involved. It's hugely important that we realise we're not just the only rare disease. There's maybe somewhere between 4,000 and 6,000 people in the UK living with ITP, but there's about 3.5 million people in the UK living with one form of rare disease or another. So, we're not alone in this area, if you like. So, yeah, please join in. Please have a look at what's going on with it, and let's just get behind it and enjoy it. Really, it's been quite good fun. You might find that I might be involved in Genetic Alliance, are the rare disease promoters in the UK, and I think they're going to use some of my material that I've provided for them, highlighting ITP. So as and when that comes out and it's published, I'll obviously let people know via the social media sites. It's possible that I might be going on TV about it, but I don't know that yet. I'm not 100%. It's not confirmed, but it's possible. So all good fun, and we'll see what happens. But do join in. Thank you. Thanks, Mervyn. I'll let you get back to other things. Yeah.
Thank you. Yeah. Right. Anyone else got any questions?
There's some in the chat. So Patricia's just mentioned about having side effects on Avatrombopag, and then has now got a prescription for Avatrombopag and is a bit worried about taking it. May I ask, Patricia, are you taking it now, the Avatrombopag, or you don't want to start it yet?
You're still muted, Pat.
Finally.
Go on.
No, I haven't. And the strange thing is, my platelets have been like 173. I've had ITP for 10 years, and I was taking the Revolade. Well, before that, I took IVs and stuff. And for 3 years, it worked fine. I was getting up at midnight. And then I had the most severe pains that came at night, mainly. And I felt like a burner had got a blowtorch and was heating me. Or, it was like being burned all over. And it got worse and worse. I almost felt suicidal. But the hematologist, he wouldn't listen to me. And I told him that suddenly my platelets had gone up, to 364 from like 88. And he said, "Oh, your platelets are normal. I don't care about your pain." It was awful for me. But the physician, the MD, he came in, and I told him in 3 minutes what happened. He said, "Get off of them right now." And he gave me a prescription for the Avatrombopag, but I'm holding off for now because my platelets, maybe I'm cured. But I carry them around with me, but I was going to be scared to take them because I thought, supposing they have the same side effects. But Catherine, you said they don't have such severe side effects. Is that right?
Well, in my experience, I found that Avatrombopag seems to be better tolerated, but it doesn't mean that you can't get side effects. I mean, I think, you know, if your platelet count is greater than 50, I would say you don't do anything at the moment anyway. How long have you been off the Revelade for?
Just a few months. Let me see.
Platelet count still greater than 50?
September. Yeah, gradually. It took me 3 or 4 months for the pain to disappear. So now I've been off a couple of months, yes.
And your platelet count still, I think you mentioned 80?
Yeah, I'm surprised. I don't know what happened. So I'm just keeping my fingers crossed. But we do my blood about every 3 months. So yeah, just keep my fingers crossed. I can't believe it. It's a strange thing.
Yeah,
because for years I had it like in the 50s, you know.
I was at a meeting. Yes, it was an online meeting, and we were talking there about how when we meet patients for the first time when they're first diagnosed with ITP, we still cannot tell them what the future holds.
Yes,
we've no idea what the journey will be for anyone when they first present with a platelet count of 2 and maybe bruising and a nosebleed or whatever the bleeding symptoms are, and we put them onto prednisolone and they're like, well, you know, what's going to happen? And I'll say, well, I'm going to give you prednisolone. I'm hoping that will work in the next few days, and then I'll try and get you off it as quickly as possible. And it may be your platelets stay up and never go down again, or it could be that as I reduce the prednisolone, your platelets could go down and we have to start another medication. It could be the prednisolone doesn't work at all, and you've got no way of predicting, and that's terrible. Well, terrible, but you know, after all this time and all the research, we still have no predictors of response to treatment. Which is frustrating. So I think, you know, who knows, you may be cured forever or it may come back. It's impossible to know. But yeah, if you can stay off drugs and your platelet count is greater than 50, then great. I think one thing I always say to people with ITP, you do not need a normal platelet count. You need a safe platelet count.
Yeah, that's true.
So you know, your platelet count is safe currently.
Okay. Diane, you got a question? And I just muted you because your feedback was coming through. So you better unmute.
What do you say?
What I was going to say, when I was on Avatrombopag, I had
Turned your camera off now as well. So yeah, that's it.
You're messing with my controls. No, what I was going to say was I had the same problems, Patricia, with my gut when I was on Avatrombopag. Less so with Romy, but the first time that I tried it over, when it first came through, I was struggling again with my stomach. So I went back onto Romy, and as I said, I've recently gone back on Ava. And what I found with it is if you really eat it with a decent meal, I mean, I literally put the tablet in the middle of the meal. I get no problems gut-wise. Having said that, I do take a really decent probiotic, and I did do for several months before I swapped to Ava. And for me, it seems to have sorted the problem. But like you, when my platelets are going up, I can get surges of heat, which is weird. Not sweats, but like a surge of heat through the body.
Okay. Thanks, Diane. Anthony, you got your hand up?
Thanks, Mervyn. Just a couple of points that just occurred to me on discussions we were having earlier on, that obviously with blood pressure do recognise that many of the treatments that we might be prescribed for our ITP will affect blood pressure. There's something that we need to bear in mind and keep an eye on. For example, steroids and rituximab seem to mess around with my blood pressure numbers. Whether that was a response to the treatments, we'll never know. But even so, it's worth keeping an eye on those figures, as we should anyway. But and the other one, I see Libya's put here, can platelets climb too high? Yes, they can, and I'm sure Dr. will elaborate on that in the next few minutes. But yes, they can, and we have to be wary of that too. So you can't win sometimes, you know.
And and I think one of the challenges I now have with when looking after patients with ITP is that Avatrombopag, L-Trombopag, Roriplostim, they can work really, really well, but all of them come with fluctuations. And one thing, as I've got experience with those drugs over the last sort of 10, 12 years, is that you have to not act too fast, and this can be really, really tricky. So, you know, someone's platelet count might be 450, which is just above normal. And you can drop the dose of the Avatrombopag, for example, and you find 2 weeks later the platelet count's 4. And what I'm finding now is I tend to not act on 1, sometimes even 2 results. I'll just check it a week later, and if it's still 450, as long as, you know, with discussion with the patient, is leave it well alone. Otherwise, it's just going up and down, up and down, up and down. And when I speak to other clinicians who don't look after ITP too much, you know, they have the odd patient, and they'll come to me saying, oh, this isn't working, the platelets are all over the place. And you talk to them about what they've done with the Avatrombopag, for example, and they're following the instructions of the booklets, but the plate's going everywhere. And so, I mean, that's just something I've sort of seen through experience. So, but then you've got to balance that against not letting the platelet count go too high. So obviously, if it's 500 or 600 and it stays at 500 or 600, then I'll very gently bring the dose down and we see what happens. So it's this real balance. And I also don't like bringing patients back too often for blood counts. And so it's just this whole balance of trying to get quality of life as good as you can, get platelets as good as you can, but not make the platelets too high. Tricky. And I think, I'm sure I said it before at this meeting, is that, you know, as a hematology doctor who doesn't look after lymphoma and leukemia, I always feel we're sort of second best because our patients don't have cancer, but it is still a really difficult disease to have, with frequent visits to the doctor, with risk of bleeding, with risk of thrombosis, with the side effects of the medicines. People like myself are just trying our best to try and get this as recognised as possible. In fact, we now have a new name. So we're now medical hematology. We used to be called non-malignant hematology, which we didn't like because we felt that suggested that it wasn't important. But now things like ITP are called medical hematology. I don't know if that gives us better kudos or not.
That is news, actually. I didn't know that. So yeah. So
I think it's been a bit driven by Sue Pavard, who Mervyn.
Oh yeah, Oxford, yeah.
She's the president of the British Society of Haematology.
She is.
The meeting that I was at yesterday, webinar, it was actually called Updates in Medical Haematology.
Oh, excellent.
It covers things like ITP, sickle cell disease, haemophilia, thrombosis.
Excellent. Thank you. Right, let's see. Any questions? Betty, have you got a question at all? No, you're muted, my love. No. While Betty's trying to find the unmute, anyone else got any questions?
Yeah, it's Liz here.
Go on, Liz.
With ITP, there's a variation in the platelets. They can vary quite a bit. What is the variability, the range for somebody with ITP?
Well, I would say anything from 0 to 1,000.
Right. So
on treatment, I mean, obviously on treatment when you get 1,000, but it's just incredible. It's just incredible. I had a lady who incredibly resistant to treatment, incredibly resistant, had her spleen taken out. That helped enormously. And then about 2 years later, she had a relapse. And when she, before her splenectomy, she was resistant to 750 micrograms of Roriplostim. That's a huge dose. So I can't remember, platelet count was like 2, she had bleeding symptoms. I thought, well, I'm not giving her 750. I'll give her 500. 1 week later, platelet count was 900.
Right, so it can vary quite significantly.
Yeah. So, and also now, probably another 3 years later, she's still on 500 and the platelet counts are sitting around 30. So it's just,
yeah.
ITP is, there's so much we don't know. I mean, 500 years from now, I literally go that far forward, everyone will be laughing at us. But yeah, that's medicine for you. But yeah, no, they can really, really fluctuate, really fluctuate.
Okay.
And I noticed as well that something that's been really important actually over this Christmas period, and Tony's just posted that just here, is that is about getting viruses with ITP. So you have to be really brave with these ones. So what generally happens is you've got someone who has quite difficult controlled ITP, but things are relatively well controlled on, let's say, Avatrombopag, and then they get a cold, COVID, flu, whatever it is, and they call up and say, oh, you know, I've got blood blisters in my mouth, or I've got petechiae, whatever it is. And, you know, their platelet count's 2. And that's a really, really hard thing. So what we've done a little bit of over the last 2 or 3 months is we've given really, so I haven't changed the dose of the Avatrombopag, let's say, but tiny dose of prednisolone just for like 5 days. And that covers them because generally the platelet count comes up again. Whereas if you just put up first of all, they probably need something anyway because they're bleeding a bit. But if you put up their Avatrombopag, you then find you've got a platelet count of 800 again. So, but yeah, God, I've had so many people relapse in inverted commas. It hasn't been a relapse because they've got better, but so many people who've had viruses over the last 2 or 3 months, and it's played havoc with their ITP.
Okay.
Yeah, we've had loads of calls from patients and, you know, members about they've had this virus and that virus over the winter, and you know, it's played havoc with their counts, etc. So yeah, it has been a problem. You
know, you can just get away with, you know, I had one lady just last week who's so hard to treat, and I just gave her 10 milligrams of prednisolone for 5 days. Her platelet count had been about 4 with blood blisters. She's on ramiprostim, kept ramiprostim the same dose, and after those 7 days, her platelet count was sort of about 30 again, which wasn't normal, but at least it was safe, and she hadn't had to have too many steroids because she hates them. So yeah, tricky.
Okay, good stuff.
Okay.
Thank you, Catherine.
Thank you.
Anthony, you got your hand up?
Yeah, just something to sort of add to that. That on social media we get quite a lot of people say, "Oh, I had the wretched virus, I had the awful bug, and my platelet counts rose." Now that I am aware can happen, and my theory behind it, whether I'm right or not, I don't know, but my theory is that your immune system is so busy attacking whatever virus you've got, it kind of switches its attention to doing that rather than attacking your platelets. Whether that is right, I don't know, but my guess is it probably is.
I like that. I like that theory.
I don't know. I guess we don't know.
I wish most ITP patients did that because most don't.
But that's the thing, isn't it? And you know, when I see people say, "Oh, my numbers went up," you know, you kind of wonder how common is that? Is that, you know, very, very much the case, or is that completely abnormal? Or it's so difficult, and it's very, as Doctor was just saying, it's so difficult to predict what's going to happen with people. You know, some react in completely different ways, and we have to just bear that in mind. Each case on its merits, I guess. That's all you can really say.
Yes. Thanks, Anthony. Rhonda?
Yes, hello, Catherine. I'd like to ask you, because ITP is an autoimmune disease, do you see many patients who also have other autoimmune disease? And if you do, what are they?
Absolutely, hugely so. So something called, so you've got your autoimmune conditions against other parts of the blood. So autoimmune hemolytic anemia, when you destroy your red cells. You can also get autoimmune neutropenia, where you destroy your neutrophils, type of white cell. But all of them, so a lot of you have probably heard of SLE or lupus. That's very commonly associated with ITP. But also there's not only, so when we meet someone for the first time with ITP, we're looking for other conditions that might be autoimmune, because that might have led to them is what we might call secondary ITP. So they've got rheumatoid arthritis, or they've got SLE or lupus, and then they get ITP on top of that. But also you can just be there with your ITP, no other autoimmune conditions at all, and then 5 years later you find you've got something called pernicious anemia, for example, which is when you can't absorb vitamin B12 because you've got antibodies in your gut that prevent you from absorbing it. You can suddenly develop what's called hypothyroidism, when your thyroid is underactive. So we know that if you get, absolutely that question, if you get one autoimmune condition, you're very not vulnerable as such, but you know, if you get another one, it's not surprising. It's not surprising. It's almost certainly something in your genetic makeup that when you get exposed to whatever in the environment, whatever it is, I mean, this is all on a hypothesis, but basically we think that autoimmunity is you see something, whatever it is, a food or a mite or whatever it is, and your body appropriately reacts to that. But then as a side effect, it reacts against your platelets or whatever. And there's something probably in people's genetic makeup that makes them more vulnerable. And that's why we say, so one thing that people always ask pregnant women when they're having children, is this inheritable? So you have to explain, no, you cannot, you know, if a mother has ITP, their child is not going to inherit ITP, but there may be a tendency to autoimmunity in the family. So they might possibly be a bit more likely to develop it. It doesn't mean they're going to get it, but they, you know, so it might be that a lady's got ITP and her mother had B12 deficiency. So autoimmune can sort of run in family due to genetic makeup, but it's absolutely not inherited.
So is there any one in particular that you see more than others?
I would say probably autoimmune hemolytic anemia. So there's actually a syndrome where patients, you know, people who present with ITP and then present with hemolysis of their red cells or present with breakdown of their white cells. It's actually got a name called Evans syndrome. Almost certainly Dr. Evans. I'd have to check that, but that's normally what happens. Because that's, again, none of this is common, as we were talking about. ITP is a rare disease, but autoimmune hemolytic anemia is one of the most common things I've seen. But I have seen, definitely seen SLE or lupus, definitely seen rheumatoid arthritis, definitely seen pernicious anemia, and yeah, also seen hypothyroidism, so a low thyroid. So I think all of it's, you know, passed me during the time I've been a doctor. But I think probably the most common thing is probably seeing other autoimmune conditions affecting the blood.
Oh, thank you. I just want to ask one more thing. When I have blood tests, I sometimes have things that come back abnormal that aren't platelets, because, you know, I've had a splenectomy and my platelets are generally about 350. So, you know, I feel very pleased with that. But there are other things in my blood sometimes that come up as abnormal. And when I say anything to my GP about it, they say, oh, don't worry about that, there's nothing. So why do they say it's abnormal when it isn't? I mean, in fact, my platelets were quite high a little while ago, and you know, and they really they weren't bothered about it at all. And then I had high neutrophils. They weren't worried about that either.
So once you've had your spleen removed, you're very prone to abnormal platelet counts, but they're not abnormal. It's just that they come up red on the screen. So because the spleen's a reservoir for cells, for blood cells. So, you know, let's say you get an infection and you get a bit inflamed, or you have an operation or something where your body gets a bit inflamed, your platelets will go up. So, you know, my platelets, for example, might go from 250 to 400 if I have knee surgery or something, because I've got a spleen. But if you don't have a spleen, your platelet may be sitting at 350, and then your body sort of makes more in response to the sort of inflammation that's happening, and those extra platelets aren't in the spleen, and so it's much more obvious. It's because you've lost the reservoir. So it would be very common for you to have slightly higher neutrophils, to have slightly higher lymphocytes. So there's a thing between having an abnormal arrow up and down on a screen and it actually having clinical meaning. And that's why, particularly because so many blood tests are done these days, you have to be so careful how you interpret the results. You don't want to start going down an alley of over investigation because you found a slightly high lymphocyte count in someone who's had their spleen removed, because that would be completely inappropriate. It's like you know, my husband used to say to me, why don't we just put everyone through an MRI scanner and then we'll know if they've got anything wrong with them. Let's do it like maybe every 5 years and then we'll pick everything up and we'll catch cancer earlier. And I said, because you will pick up, so we call them incidentalomas in medicine. You will pick up little tumours on the brain. You'll pick up little tumours in the spleen or in the liver. They're probably benign. They've probably been there for 10 years. And they'll probably never cause the patient any harm. And once you found them, you're obliged to do something about it. So it's a real balance about what's important and what isn't.
Very much.
Yeah.
Excellent.
When I was having that terrible reaction from the Revelade, I noticed that many points in my blood were out of range, you know. But, you know, now that I've recovered from that, they're all normal except for globulin. So, yeah, that was interesting.
Yeah, I mean, was there some sort of inflammation going on? It's difficult to know.
Yeah.
Betty's off mute now. I don't know if Betty had anything to say.
Betty, you got a
Yes,
question?
can you hear me?
Yes, we can. Yeah, go on.
Yes. Yes, I'm on an Avatrombopag, and as you say, I varied quite a lot, and it went down, and now that they're not panicking and putting it up, you know, they're letting it stabilize, and that has worked because I've been
Good.
quite stable for a while. But I wondered about diet. You know, I know we should have a balanced diet, but things like garlic and black chocolate and things that's in the blood, are we okay to eat anything or?
Pretty much. Yeah, I think, so there's a lot of things out there about, so when they talk about, so turmeric's another one. So there's a few things in food that has been shown to maybe reduce, make platelets less active, or make some of the clotting factors more or less active. But I think, you know, I wouldn't, nothing out there. There's a few, and it's not to do with ITP, there are a few drugs out there and a few foods out there that you absolutely cannot put together. Classic one is grapefruit and statins, which lower your cholesterol. But on the whole, there's really, apart from Avatrombopag, which is obviously the big one, where you have to really be careful about dairy and other, what am I trying to say? Small, what am I trying to say? Things like magnesium and calcium and things like that you can't take, so you won't absorb the Avatrombopag. There's really nothing that you can't, unless you're guzzling down 6 bulbs of garlic a day. It's fine. Just have a healthy, balanced diet. It's absolutely fine.
Okay, thank you, Betty. We're coming to the end now. Anthony, you got your hand up?
Yeah, just on the nutrition bit, there's also mention of pecan nuts and all sorts of, but you'd have to eat an awful lot of them to I think, affect your platelet count. But on one thing, it's kind of nutrition linked. If you're on a PPI drug, like omeprazole, which you might well be if you're on steroids, when I was on steroids and omeprazole, I ended up having a major drop in B12 and folate, and we pinned it on the fact that I was on omeprazole, in the sense that it does interfere with your tummy acids and your tummy balance. So I don't know if anyone else has encountered that or if it's a common thing, but it's something worth checking. I mean, I was getting real tiredness and fatigue, extra fatigue, you know, compared to normal ITP fatigue. And it was because my B12 and folate levels had dropped quite a bit. But I mean, I take a supplement on both of those now anyway, as a matter of course, and my levels are absolutely normal. But I'm not on omeprazole and haven't been on it since 2016. So, I mean, whether there's any link to that, I don't know. But I think it does interfere with the balance of your tummy acids. So it may be something to be aware of. I don't know.
And this is the thing, you give one drug it has side effects. To counteract those side effects, you give another drug, and that drug has side effects. And prednisolone and omeprazole is a really good case in point. If we didn't give omeprazole or something similar with prednisolone, you run the real risk of getting terrible gastritis, a real inflammation of the stomach, even possibly an ulcer. And so we know we can really reduce the risk by giving things like omeprazole. Omeprazole affects your stomach acid, so that can affect the absorption of other nutrients. So it's a real delicate balance. I mean, steroids, I mean, I'm sure probably most people on this call have had steroids, and I know everyone absolutely hates them. I don't think I've met a single person who says, steroids, they're fine. But they really have their place in ITP, but we need to learn as doctors to use them lowest dose, shortest period of time, which I think we're slowly getting better at.
Okay. Before we, Diane, you're on mute because I muted you again.
Poor Diane.
Sorry.
He doesn't say anything by it.
I know, he keeps muting me. Just a quickie, just following up on what you were talking about, this predisposition, maybe familial predisposition to autoimmune. I had an aunt that died of pernicious anemia, and I was told all along that nothing to do with it at all. My question is, if you have or had someone in the family who had another autoimmune disease, would it necessarily follow that would be the one, or is it just it could be any other autoimmune?
It could be any other autoimmune condition, any other autoimmune. Basically, that there's sort of there's various proteins in the blood that are on our cell that sort of our genetics sort of make us. You know, when people are being matched for bone marrow transplants or organ transplants, those sort of proteins, certain combinations of those can make you more vulnerable to some of these autoimmune conditions. And so the theory is that, you know, you inherit some from your mother and some from your father, and you may get a particular combination that makes you more or less autoimmune. But it's not a given, and it's not if someone in your family's had ITP, you're going to get ITP. You might do, but it's more a sort of a tendency to autoimmunity that may run through families.
Thanks. Thank you.
Okay, thanks, Diane. Thank you. Right, any other questions before we close? No? Okay. Just like to thank Catherine. Quick one before we do go. Don't forget we got our annual patient convention on the 10th of May, and it's taking place at Bridgewater Hall in Manchester. So Diane and I was up there last Friday just to check it out. The venue's beautiful. It's going to be a lovely event. We got a superb agenda going, some great speakers. Catherine's also there. So yeah, so it's going to be a really good event. And I believe, Catherine, you're at a BSH in Glasgow doing something.
Oh, I'm doing far too much at the BSH.
Yeah, I think we're both on one of the same things, I believe.
All right, well, I'm talking about Evans syndrome. So that's the. I'm
on something else. Yeah, but yeah.
Oh no, I know what you're talking. I think I know. There's a sort of patient
symposium going on with Novartis.
Patient symposium, I think, going on with various aspects of different heme.
That's it. Yeah, we're both on the same thing.
Yeah. Well. Yeah.
Great stuff. And I've got one of our colleagues, a patient from Scotland, actually going. Rhonda Bowie, so she's going to be there with us, so that's great. Okay, thanks everyone. Thank you for taking part,
and I hope that maybe I'll see some of you face to face at the patient meeting.
Yeah, it'd be great if you could all come along to Manchester.
Because I don't think I've met any of you in person. I don't even think I've met you in person, Mervyn, have I? I don't think so.
No, we haven't. No, we haven't. No, never. No,
so there's the new world for you.
You're in for a shock, girl. You're in for a shock.
He's not joking.
Diane, shut up. Right, I'll have to cut that bit out. So yeah. Okay, thank you, everyone.
How would you get? How would you get to the convention? By train?
Yeah, train from London. Yeah.
And then is it a
Coast
walk?
Main Line.
Is it a long walk?
No.
From where I live here, it's probably about 2 hours by train.
2 hour walk?
No. Patricia was asking how far from train station to venue.
The train station to the venue?
Yeah.
It's about 10 minutes.
10 minutes, yeah.
By cab. Anthony, you got your hand up?
Yeah, just a very quick thing. I've put it on the chat there, but don't forget it's our 30th anniversary this year of the ITP Support Association, and Mervyn will be putting together a sort of summary, an anthology, if you like, of people's comments about their experiences with the ITP Support Association. So hopefully all of those comments will be good and positive. If you've got any sort of stories or memories or experiences with us and about the association, how it's helped or whatever, we'd be grateful if you could kindly send them into to the ITP Support Service HQ. It's I've put the email address there, so please do. It's yeah, we're looking forward to it. It should be a really good year ahead for us. So
okay,
do send them in.
Thanks, Anthony. Thanks for that reminder. I forgot all about that. So
yeah, I did too.
Thank you. Okay, everyone. Take care. Thank you.
Everyone.
Bye.
Have a good evening, everyone.
All the best. Bye-bye.
Thank you, Catherine. Thanks.
Bye.